And welcome to the McFarland Clinic webinar, Immunization Update, Flu, COVID, RSV, and more. My name is Kelly Hartwig, Employee Health Coordinator at McFarland Clinic. I'll be serving as your host and moderator for today's presentation. Thank you for attending this webinar today. We will be covering vaccine updates for influenza, COVID, RSV, and pneumonia. In addition, our speakers will provide an update on the status of measles and pertussis. We have two speakers for today's webinar, Dr. Dan Fulton, Infectious Disease Specialist, and Dr. Jacob Kolker, Pediatrician. Before we get started, I do have a few housekeeping items for you. When you registered for the webinar, we gave you the opportunity to ask questions ahead of time. Our healthcare professionals have incorporated the answers to many of those questions into today's presentation. Please note you can also submit questions anytime during today's presentation by using the Q&A function at the bottom of the control panel. We will address as many questions as we can during the Q&A session at the conclusion of the presentation. We are also recording this session. You will receive an email when that video is ready. The email should be sent to you no later than Friday, October 3rd. And lastly, when the webinar ends, you'll see a link to a short survey. Please take a moment to complete that, as your feedback is important to us as we plan for future sessions. At this time, I would like to welcome Dr. Dan Fulton as our first speaker. Thank you for taking time to share your expertise with our many viewers. I'll turn it over to you to start us off.
Thanks, Kelly, and thanks for the opportunity to be here with you all today on the webinar and talk a little bit about vaccines and our strategy going into especially this respiratory virus season. I think the way we'll handle our discussion today is I will focus primarily on adult-related vaccines, and then Dr. Kolker will talk about the pediatric aspects of those vaccines. And depending on the particular disease, whether it's more a pediatric or adult-focused disease, we'll kind of start and follow up based on that. So again, I'm Dan Fulton. I'm an infectious disease specialist here at McFarland Clinic. I've been here about 10 years now and have been very involved throughout that time and in my training with both the treatment and prevention of many of the illnesses we're going to talk about today. So let's start with influenza. Our goal with these talks is going to be to talk about these diseases and vaccines at a fairly high level. Any of these diseases could be its own talk. Any of these vaccines could be their own hour-long talk. But let's hit them at a high level and then try and get it open for questions at the end. So influenza is a very common virus that circulates around the globe, but in this part of the world, it's primarily a winter illness. Onset is usually in December or January. It just kind of depends on the year and certain circumstances. It's a pretty mean virus. People get high fevers, body aches, and it can move on to cause pneumonia or even respiratory failure on its own accord. And then the other thing about influenza is that after somebody's recovering from the virus aspect of that infection, they can then get a secondary bacterial pneumonia, usually from a staph or strep infection that can be also just as dangerous. So there's millions of these infections that happen in the United States every year. Many people end up needing to see their doctor because they are so ill. So this is usually beyond the common cold for many people. Many people get hospitalized and many people die related to this infection. One of the reasons influenza is so successful is that it is able to change the proteins on its kind of covering and kind of shift those around. And so then our immune system has a harder time remembering it from year to year. I think most people are familiar with the symptoms of fevers and body aches and just being really sick. We do have some treatments for influenza called oseltamivir, or people may be familiar with what's called Tamiflu, the same thing. The challenge with those medicines is that they are most effective when they're given very early on in the illness. And frequently people, start to get sick. They may kind of watch it for a day or two to see where is this illness going. And by the time they're starting to get very sick, the virus is kind of already on the run and antiviral medicines may not be as effective. So because of that, vaccines really are the best approach when it comes to influenza. Whatever we can prevent will pay dividends in the long run. So this year, influenza is three strains. In the past, it used to be the vaccine used to cover four strains, but as sort of a side effect of the pandemic and all of the masks for a couple years, actually one of the B strains we used to need to vaccinate against sort of went extinct. So now we only need the three. So this is a vaccine that's given yearly. We give a slightly higher dose to people over 65 or 65 and older, and it can be given with other vaccines at the same time. Uh, this vaccine is very effective at decreasing your chance of getting influenza at all, which translates into not missing work, not missing family gatherings, not being sick. But then even if you do get sick after getting the influenza vaccine, it is very effective at blunting the disease that you got. So instead of ending up in the hospital or potentially dying, you may only get a fever and some body aches that last for a day or two. So I do hear that people will comment that I got the influenza vaccine and I got sick anyway. And that may be true, but I also feel like frequently people don't get as sick as they would have otherwise gotten. In general, influenza vaccines are incredibly safe. People sometimes will get a little bit of a sore shoulder afterwards, which is common for many vaccines and usually not very significant. I especially I can say from my own experience, I don't have much for side effects with the influenza vaccine, and large studies show that side effects are rare. There's always a possibility of a rare allergic reaction. And those things are very, very rare. So we do get some frequent questions when it comes to influenza vaccine. One is about egg allergies. Some of the influenza vaccines are prepared in chicken eggs. And so there used to be a concern about a person who had an egg allergy couldn't take influenza vaccines. And it turns out that that's been studied at great length. And even people that have severe, even life-threatening egg allergies, it's been found that there's just not enough egg in the influenza vaccines prepared in eggs to cause any problem at all. So actually, egg allergy is not a contraindication to getting an influenza vaccine in any way. Additionally, I frequently hear it said that after I got an influenza vaccine, then I immediately got sick with a virus, with some respiratory illness, and I got an infection from my vaccine. And these vaccines, the injections, they're not living things. They're just dead virus proteins, so they don't have the actual ability to cause infections. What's probably happening when somebody gets sick afterwards is that we give these vaccines at the start of respiratory virus season, around now, and this is when respiratory viruses are starting to circulate. And so when people get sick after an influenza vaccine, that's a coincidence that they happen to get something when they got their shot. These shots don't cause infection. And if that happened to you in the past, the chance of that happening in the future is, no higher than anybody else. If you get the influenza vaccine every year, studies have actually shown it's more effective. So as that virus tries to shift its proteins around, we do change the influenza vaccine itself, targeting which virus we think will be the most common in our region this year. There are studies that show if you get it every year, even if it was the same vaccine as last year, that it makes the vaccine more effective. I think one last thing here in Iowa, we've heard a lot about avian influenza this year, and the seasonal influenza vaccine is targeting different proteins, and so really doesn't have much to do with avian influenza. But fortunately, we really haven't seen any even minor signals of jumps into the human population for avian influenza. So I don't have sort of major concerns about that. I think one last thing when it comes to influenza vaccines is there was a recent change in CDC and ACIP, the sort of guidance giving bodies in the United States with regard to influenza, and a product in that called thimerosal, which contains mercury. Basically that can't be in influenza vaccines right now. And That really isn't used in the United States in any meaningful way. That product is used only in bottles where somebody has multiple vaccine doses in one bottle, and the needle is going in and out multiple times. All of the vaccines that we use here and in general in the United States are one-time use bottles, so already didn't contain that product. I think the bottom line for me with influenza is this is a severe infection. And even with massive vaccine campaigns that we've been undertaking for many years, we in the hospital still see so many patients that get severely ill from this infection, many of them who weren't vaccinated. And I think whenever I see a disease that's really showing up in the hospital, it tells me I really think we need to do everything we can to prevent it. So I would really encourage everybody to get vaccinated for influenza. Protect yourself, protect your families. Try not to get sick this winter, and we'll all do the best we can. Dr. Kolker, I think we're ready for the pediatric part.
Awesome, thank you. So, a lot of the information that Dr. Fulton just provided is the same for pediatrics in the sense of the vaccine decreases severity of illness. It also decreases the risk of severe complications in children, including, pneumonia, encephalitis, which is an infection of the brain and spinal cord. And, there's also a number of children that die every year from influenza as well. So the recommendation for kids is yearly vaccine starting at 6 months. Children under 6 months are not eligible to receive the vaccine. So we generally recommend that all caregivers and people that are going to be around the child during the cold and flu season receive their influenza vaccine to help confer protection to those really vulnerable patients less than 6 months of age. So it's a yearly vaccine for kids, except the first year that they get it. So the first year that the vaccine is given, it's recommended to do 2 doses, at least 28 days apart. And that helps their body respond better to the vaccine and gives them extra protection when they are, small and very vulnerable to severe infection from influenza. That's the recommendation for kids under 8 years of age. Over 8, it's just a one-time shot. So if they're receiving their first dose 8 years of age or older, it's just one shot that season, and then yearly after that would be the recommendation. So I think that's about all I have for influenza. All the complications that Dr. Fulton talked about, we see in kids. The one that's you may hear a little bit more on, TikTok and social media is the encephalitis, which is a known complication that the vaccine definitely decreases the risk of that and the severity of other complications.
Thanks, Dr. Kolker.
Yeah.
So let's talk about COVID-19 and its vaccination. So I think most people are quite familiar with COVID after we've lived through the recent pandemic. There are actually a number of different coronaviruses that cause human respiratory infections. Most of them are I would call mild to moderate colds. But COVID-19, because it was a new virus that our immune systems had never been exposed to, when it came on the scene in 2020, really caused profound and severe disease, resulting in many deaths worldwide and here in the United States and in our community. This virus, is most associated with its worst complications, which are respiratory failure. Basically, it causes inflammation in the lungs and makes it impossible to breathe. But it can cause a range of symptoms from asymptomatic infections that people didn't even know they had, to cold symptoms, to kind of all the variety of different things that people described, especially in the early days. I do think as people have more developed immunity now through either being infected or vaccinated or both, For the most part, the severity of these infections seems to have decreased dramatically. We're very busy in the hospital with people that were very sick until kind of early 2022, and it seems like since then the amount and number of people in the hospital with COVID has decreased dramatically, I think, for those immune related reasons. We still occasionally, though, do see patients that are admitted to the hospital because of COVID, often because it's exacerbating some of their other chronic conditions. It is still a severe infection. And I also think many people that get COVID infection who've already been vaccinated or had it before still describe a fever illness with body aches and feeling pretty sick. They miss work, they miss sports, they miss travel. So it is still a disease process that is making people sick. There are treatments for COVID. The Paxlovid combination pill is available. It's very similar to the oseltamivir or Tamiflu treatments for influenza, where it really should be given pretty early within the illness course. And I think studies have shown that it's probably most effective for people that are at highest risk of COVID getting worse. So people that are at extremes of age or have other medical conditions. One of the challenges we face, especially in the adult population, is that there's a number of drug interactions with that medicine and other medications. So sometimes it's not a good option to use. And so because of that, prevention remains the best approach. If we can prevent the disease from happening or from being severe, we can prevent a lot of downstream complications. The COVID-19 vaccines have been studied really extensively and are very effective and very safe in a wide variety of populations. There are several formulations that I think most people are familiar with. There are two primary mRNA vaccines that have different sort of age minimums associated with them. mRNA is basically a little packet of information that teaches your body to make a protein that is similar to what is on the COVID virus, and then your body learns to recognize that protein and then recognizes COVID more quickly so that it doesn't make you sick. The Novavax vaccine is not an mRNA. It's more of a standard protein and subunit vaccine that just directly puts the protein in, similar to an influenza vaccine, and then the body recognizes that protein, makes an immune response, and then it can recognize COVID infection early. The ACIP and CDC have recommended that this vaccine continue to be given to people 65 and older and those with high-risk conditions. There are many potential high-risk conditions that I won't take the time to name, but I've read a statistic that about 75% of the adult population between 18 and 65 actually has one of these conditions to begin with. So there are potential benefits for a wide range of people. For people that don't have those conditions, the ACIP has recommended that the vaccine is still available to anyone, but that you should talk with your doctor about the potential benefits if you're otherwise healthy, to see if it's something that makes sense for you. Although that might sound like a change from prior policy, and it sort of is a technical change, if we look at the guidelines over the last couple years about COVID vaccines, the CDC has already been recommending over the past 2 years that COVID-19 vaccination is recommended for everyone, but especially those at higher age of 65 and older and people with medical conditions. And I think there's been growing recognition that those are the primary risk groups that should definitely be getting the vaccine, and that lower risk groups, there is not as much urgency to get the vaccine, although because of regulatory reasons and payment reasons around the vaccine, previously they'd continued to say everybody should just get it. What we are hearing, at least as of now, is that with the way the current recommendations from ACIP and CDC are formulated, that insurance companies will continue to cover these vaccines basically for anyone that wants one. So that's kind of what I just said, but basically, if you are 65 and older, I would definitely recommend getting a vaccine. I would recommend getting a vaccine this fall. It's formulated for the COVID-19 sort of variant that's been moving around. The Omicron variant has been the primary variant now going back many years. There are some subtle changes to it, but no major changes to it. I think if people got vaccinated in the spring of last year, especially if they have weakened immune systems or at extremes of age, getting a fall shot in anticipation of our winter COVID kind of wave that will come through would be a good idea. Also, if you have chronic medical conditions like asthma or diabetes, it would also be a good idea because you're at higher risk of getting more sick. I think one area that's been uncertain has been the recommendations with regard to pregnant women. The American College of Obstetrics and Gynecology continues to recommend that pregnant women receive COVID-19 vaccination. Pregnancy by itself is associated with higher risks of severe COVID infection and also complications for baby. So we continue to recommend that pregnant women get the COVID-19 vaccination. I also think there's some discussion to be had about somebody that has a very low risk themselves, but if they have regular interaction with people that are high risk, like perhaps they're a caregiver or a close family member that is at high risk, that getting vaccinated may decrease the chance of being contagious, especially in the several months after vaccine. And that may help kind of create that protective bubble surrounding the at-risk person. If you aren't in any of these high-risk categories and you're thinking about getting the COVID-19 vaccine, our recommendation has been and still is that the person that knows you best as far as your health would be your own medical provider. And talk with them about questions you have or what they think with regard to your health and whether or not the vaccine would be good for you.
All right. Thanks, Dr. Fulton. So like Dr. Fulton talked about with the ACIP recommendations being very similar in pediatrics, with that being a shared decision between your provider and the parent of the child or the child themselves. The AAP, American Academy of Pediatrics, has some slightly different recommendations. And so that their current recommendations coming from the AAP do recommend that all kids, 6 months to less than 2 years of age, recommend that all kids receive a 2-dose series of the new COVID-19 vaccine for this year. And that has been shown based on some studies that have been done to show that kids less than 2 years of age are at increased risk of severe COVID-19, including hospitalization, respiratory failure, and all the other complications that go with that. If the child has completed that primary, say a child is between a year and 2 years of age and got that primary series last year, they would just need their yearly one of the 2025-2026 vaccine. Next slide, please. And then the AAP aligns with the ACIP in kids 2 through 18, where, if a child or the parent desire protection against COVID-19, it is recommended that they be given that vaccine if they desire that through shared decision making. But they do also strongly recommend it for kids that are high risk. There's kids that have chronic lung disease, heart disease, diabetes, asthma. All those kids are at high risk of complication from COVID-19. People that are whose household contacts are at high risk, immunocompromised parents, parents who have asthma and those other things that put them at high risk. The children getting the vaccine can offer some protection there too. I think there might be one more slide, maybe. Oh, no, so that was it. So, really no big change from that. Kids are kids 2 through 18 are at less risk than the younger kids. So definitely the smaller these kids are, all these respiratory viruses tend to be more severe on their developing lungs. Uh, no major changes with regard to the recommendations. So I'm going to start talking about RSV. So RSV is respiratory syncytial virus. You can go to the next page. So RSV is a super common virus. It tends to affect all ages. Severity tends to be based on age. So kind of similar to what I said about influenza and COVID. Kids less than 2 years of age tend to be at the highest risk, with even a higher risk less than a year of age. Worldwide, RSV is the number one cause for hospital admission in children less than a year of age. And we have been seeing that, really significantly decreasing over the past 2 years with the advent of two new therapies. I don't want to call it the Beyfortus and immunization because it is a little bit different than the other immunizations. And then there's the Abrysvo, which is the maternal immunization that pregnant mothers can receive to help offer protection to their child. So I'm just going to kind of go into a little bit about Beyfortus and how it is a little bit different than the flu shot, COVID shot, any other shots that we get. I don't have that written down. I'm sorry, but so it's a monoclonal antibody similar to. So it's a little bit different in the sense that it's not a dead piece of the virus itself or a dead protein from the virus. So it's not causing the child's body to mount an immune response. It's more passive immunity in the sense that it gives them protection that will last for 6 months during that first RSV season. And then the body naturally degrades it and excretes it. So kind of similar to how breastfed babies receive antibodies from their mother for things that mom has been exposed to. Unborn children receive antibodies through the placenta and the umbilical cord while their mother is pregnant. This is kind of similar in that way, is that it's more passive immunity rather than active immunity with the body mounting an immune response. So all kids less than 8 months of age entering their first RSV season, which starts tomorrow on October 1st, are eligible for Beyfortus unless the mother received the RSV immunization during pregnancy. So if your child is less than 8 months of age and you would like to have them protected against RSV, that's something that they would be eligible for starting tomorrow. Studies of Beyfortus specifically have shown to decrease the risk of hospital admission from RSV by 80 to 90%. And I will say in our clinic here in pediatrics, I think we have seen over the last 2 years that has been the case here as well in Ames. Nationwide studies have shown that the overall rate of RSV hospitalization in the last 2 years has dropped anywhere from, like 15 to up to 45% compared to pre-pandemic levels with the advent of these two new therapies. So it works very, very well and is very safe for these most vulnerable population.
Thanks, Dr. Kolker. I just find that so impressive. When I was a medical student, I took that rotation in the wintertime, and it just felt like we just admitted kid after kid after kid with RSV infection needing to be in the hospital to get treatment. And these treatments, both vaccines for mom and the monoclonal antibodies for kids, have just been such a game changer. In terms of the number of kids ending up in the hospital is so far down. I
just want to add one more thing. I mean, I would just say it's really crazy. You can probably count on two hands the number of kids that I've admitted for RSV in the last 2 years. And I mean, again, through training, you'd see, you know, 15 to 20 kids a day, you know, in the hospital, you know, for RSV. So it is really, really been just kind of game changing for the pediatricians here. So it's been really great.
As far as adults go, over the past couple years, we also have gotten vaccine available for adults. We don't normally think of RSV as so much of an adult illness, so much as that little kid type of illness, but it does turn out that especially people at risk or at extremes of age are at risk of getting this bad respiratory virus that sort of infects the airways primarily. And 100,000 people or so get hospitalized every year, and about 10,000 people do end up dying from this infection, frequently because they have other medical conditions. But if we could prevent that, that would be so great. And so when this vaccine became available over the last couple of years, I think we've also seen just, it seems like fewer people getting admitted with RSV infection. The challenge of RSV is that there's not great treatment for it. And so it's really, you're relying on your own immune system to get you through that process. And even if you are a relatively healthy person, I've seen these RSV infections just take forever to get better. It's just this cough and respiratory stuff that goes on for weeks and weeks. People end up getting put on antibiotics because they're just not getting better. And it's just the RSV takes a while to get better. So because of that, vaccines are recommended in specific populations. If we could go to the next slide, you know, the vaccine itself is recommended for everybody who's 75 and older. It's a one-time dose. It's not an annual dose. Right now, early studies so far aren't showing any major benefit of getting it every year. Immunity seems to hold from year to year after just the single dose. I think we'll learn more about that over time, and there may be repeat doses in the future at some interval, but we'll see. Previously, the recommendation was people 60 and over with medical conditions or just, you know, based on their general health could consider getting this vaccine after a shared decision-making process with their provider. They've actually decreased that to 50 now because there have been people in their 50s who've gotten severely ill related to this, and the vaccine has been shown to be very safe. So basically, if you're between age 50 and 75, having a shared decision-making discussion with your provider, especially around your other medical conditions and whether or not they put you at higher risk of severe disease, is worth doing. And for you, it may be beneficial to get the vaccine also. I would definitely say 75 and older should be vaccinated for RSV. Anybody 18 and older from the adult standpoint who is severely immunocompromised, so think about patients getting chemotherapy or organ transplants or that sort of thing, we also recommend it in those settings because they also can get very ill from RSV. And then, as Dr. Kolker mentioned, pregnant women get this vaccine between weeks 32 and 34, and it's so neat to me that mom's immune system responds to the RSV vaccine, develops a protective response, and then mom's immune system is able to pass to baby and then protect baby during those early kind of vulnerable months. I just think that's a really cool phenomenon. Bottom line is the vaccine decreases your chance of getting really sick, needing to go see a doctor, or potentially getting hospitalized or worse. The risks are very low. Soreness at where the injection goes in is possible. And then there's this phenomenon called Guillain-Barré, which is a numbness and nerve dysfunction that can happen very rarely if the immune system turns on to fight against or to respond to this vaccine. It can sort of cross-react with the nerves. So those are felt to be pretty rare reactions, but obviously if that's ever happened before to a person or they have concerns about that, they need to talk with their provider. From a pneumonia standpoint, so I think many people have heard of the pneumonia shot. Pneumonia, or the pneumonia shot specifically, is actually targeting a very specific type of pneumonia called Streptococcus pneumoniae. It's also referred to as pneumococcus, which means the same thing. Basically, these types of strep infections, which we've all heard of strep throat, that's caused by group A strep. This is a cousin of that. It's not the same type of strep, but it's another strep infection. But this bacteria is the most common cause of pneumonia historically. And what it does is it sort of covers itself in a layer of sugar, a capsule or a coat of sugar, and it changes those sugars around, and that keeps our body from being able to recognize it as quickly as it should, and that allows the infection to sort of get going and make people very sick. And then once it's in, it can also cause an infection in the lining of the brain called meningitis. The challenge we have with these infections is that Streptococcus grows so quickly that by the time somebody knows they're sick, this infection is just off to the races. And so you can come in and get antibiotics and get all the right treatments, and it sometimes is just too late. The bacteria is too far along. So this results in over 1 million hospitalizations per year and 40,000 deaths because of that phenomenon. People that have other medical conditions or are immunocompromised, it just kind of exacerbates that trouble of recognizing the infection is happening and starting to feel it and getting sick. And so it gets more advanced before people get in for care. So we do have antibiotics for pneumonia and especially Streptococcus, but the challenge is that it just moves so fast. So because of that, vaccines are available, and this is what we call the pneumonia shot. And I just think this is a really interesting story that these vaccines were originally developed for children, and because it can cause pneumonia and meningitis in kiddos too. But what was interesting is they started vaccinating kids to prevent childhood disease, and then adults started getting fewer infections also, not because they had been vaccinated, but because they weren't catching this infection from the kiddos, because the kiddos were no longer getting sick. And so then they started extending the idea of, well, what if we vaccinated adults? And so in 2010, pneumonia shots started to become available. I think what's been confusing about the pneumonia shots over time is that the technology continues to improve. So because of all these kind of sugar layers outside of the infection, we try to target as many of those as we can. The original, Pneumovax 23 had 23 sugars, but it was only sugar, so the immune system didn't remember it all. So then they added a protein with 13 types, and that was better. And over time, we just keep increasing the number of different subtypes that this targets, and it's very effective for those subtypes. And so the best recommendation I have is, depending on which shots you may have gotten before, that may affect which shot you need to get now. For example, if you got the original shot, well, that needed to be repeated in 5 years because the immune system didn't remember it. If you had gotten that one, but then you got a protein one, that might be different. So my advice is to talk with your provider, and based on your history of these vaccines, that will help them determine what's the best vaccine you need now, if you need one at all. You may not. But they are recommended for everybody over 50 or any adult with immunocompromising conditions. It decreases all this terrible disease enough that we really don't see this condition frequently in the hospital anymore. Again, in my training, we were taking care of people with severe streptococcal infections every day, and we just aren't needing to anymore. These are also very safe. Some injection site soreness, rare allergic reactions, but again, this is not common to have side effects. So really grateful that this vaccine is available, because it's really, I think, helped our patients.
Yeah, thanks, Dr. Fulton. Yeah, so like Dr. Fulton said, the initial vaccines were given to children, and there's been lots of different subtypes of Prevnar over the years. Prevnar 7, 10, 13, 15, and now currently a Prevnar 20, which protects against 20 groups, serotypes of the pneumococcal bacteria itself. So the primary series for all kids is given at 2, 4, and 6 months of age, in addition to the other primary series vaccines. And then kids get a booster dose at 12 to 15 months of age. And then if they receive all of those, kids are considered fully immunized. With the advent of the Prevnar 20 compared to the Prevnar 13 and 15 that was previously given, there are some changing recommendations for older kids that have immunocompromising conditions such as on the screen, diabetes, asthma, cochlear implants, heart disease, sickle cell disease, functional or anatomic asplenia. So those kids who were previously fully vaccinated with Prevnar 13 or 15 and have not gotten the polysaccharide vaccine, the PPSV 23, it's recommended that we do a single dose of the Prevnar 20 just to increase their protection to those additional serogroups. But otherwise, not many changes with the recommendations for the Prevnar vaccine in kids. Obviously, as Dr. Fulton mentioned, common cause of pneumonia, and then the most common cause of meningitis in those young kids less than 2 years of age. I think we can go to the next slide if
it looks like we might be
having some technical difficulties.
Issues. Yeah. So Dr. Kolker, I think next we were going to talk about measles. Wanted to talk about measles, and then we'll do pertussis after that.
Yeah. So measles, obviously there's been a very large outbreak that's been ongoing in the United States so far this year. So I had on the slides the exact number of cases, but I think it's upwards of 1,500 cases so far this year as of September. On the good side of that, it seems like the current outbreaks are starting to get a little bit more under control in the sense of there's been definitely fewer cases in the Texas outbreak that accounts for the largest number of those cases so far in the United States. We've obviously had some scattered cases here in Iowa, luckily none in Story County so far. But measles is a viral infection that tends to cause high fever, rash, cough, runny nose, and a fair number of people will be relatively unaffected by the measles, but there are definitely a lot of kids that can be severely infected, leading to hospitalization. And then obviously there have been a few deaths reported in this outbreak so far this year. And the best way to protect against measles is the MMR vaccine. So typically the MMR vaccine is given as a 2-dose series. First dose at 12 months of age, second dose at 4 years of age, as those kids are getting ready to enter preschool and school, just to boost their immunity, their immune system's response against measles. That second dose can be given as soon as 28 days after the first dose. So, parents that have a kid in that, 1 year age right now, if they wanted to get the first shot, and then, the first shot's about gives about 95% protection. Second shot gets you up to about 99% protection. So if they wanted to get that second shot earlier, they can do that. And the children would be considered fully immunized and then not need that dose at 4 years of age. So that is one thing that parents can do. So we can give that second dose earlier than 4 years of age if you would like. And then the other thing is while this outbreak has been going on, we've gotten a lot of questions about, well, I have an 8-month-old or a 9-month-old. What can I do to offer them protection? And kids 6 months to 12 months of age can receive the MMR vaccine. It would be an extra dose in the sense of the recommendations. It still would be recommended that they complete a 2-dose series after the 12 months of age, so it would just be an extra dose. But there are things that is something that you could consider if you feel that it is necessary, and your healthcare provider should be able to offer that to you between 6 and 12 months of age if you would like that. And then kids less than 6 months, there are options with regard to like post-exposure prophylaxis with immunoglobulins and stuff like that too. So if your child less than 6 months of age was exposed to someone with measles, that is something you could do. I also, I think that's all I have for this, but I wanted to bring up one point that the ACIP mentioned about the MMR. So there's two vaccines, MMR and then MMR varicella combined. So MMRV more commonly, and kids between 12 months and 2 years of age, there has been shown to be an increased risk in febrile seizure when the MMR is given in addition, combined with the varicella component. So if kids that get that MMRV less than 2 years of age, there is a slight increased risk in febrile seizure. Here in our clinic, we separate those all out. So it's MMR in one shot and varicella in a second shot, just to decrease that risk. But I think that that's about all I have for measles.
Thanks, Dr. Kolker. Yeah, so this is primarily a pediatric discussion. The thing that just strikes me about measles, it is so contagious. So contagious that if you were born before 1957, we just assume you had it because everybody got it because it was so contagious. And we're talking about hundreds of thousands of kiddos ending up in the hospital and getting super sick over the years that we just don't see anymore. Iowa's vaccine rate for measles is around 89%. And, it is so contagious that at that level, we start to run risks of having outbreaks. And so that's why, even though we don't have any cases in Story County, this is something we just cannot take our eye off the ball because it can so quickly get out of hand like it did down in Texas this year. From the standpoint of adults, everybody over since 1957 before was already immune. Thereafter, there's been vaccines. Basically, there's nothing specific that adults need to do unless we end up in a vaccine or in an outbreak scenario, which we are not. If an adult was traveling to an outbreak area, they could talk with their regular provider and get a measles level checked. And if they did not have protective immunity on that blood test, then they could get a new series of vaccine to generate that immunity. But generally speaking, immunity, once you've gotten your childhood vaccine, is a lifelong protection. So there's really nothing adults need to do differently. Although I would note that this is a live virus. It's weakened, so it doesn't generally make people sick, but it can't be given to immunocompromised or pregnant people. So I think the idea is if you are vaccinated, you are also helping protect vulnerable people.
And then I'm going to just talk a little bit about pertussis as well here. So pertussis, more commonly known as whooping cough. And there's also been a pretty significant increase in that over the past few years as well. Over 10,000 cases were reported so far this year. I've personally seen a couple of cases in the past 6 to 8 weeks here in the clinic as well. So this is kids are given protection from pertussis through the either the DTaP vaccine or the Tdap vaccine. The Tdap, diphtheria, tetanus, and pertussis vaccine is usually given at 2, 4, and 6 months of age, in addition to a booster dose at 15 months and then a booster dose at 4 years of age as well. Then in kids over 7, the Tdap is no longer recommended, or the DTaP is no longer recommended, and it becomes the Tdap, which is tetanus, diphtheria, and pertussis if they are not previously vaccinated. And then routinely we give a booster dose of Tdap at 11 years of age. Though there are certain circumstances where children are given that 11-year dose after around 10 years of age for like a cut or something where they need tetanus protection, that counts as their like booster dose too. So not every kid will get it right at 11, but that's a very kind of rare circumstance. We tend to see, obviously we've seen an increase in this for, I think, a multitude of reasons. One being under vaccination, but two, there's also waning immunity. As farther you get away from receiving the vaccine, the immunity for pertussis specifically tends to wane a little bit. And I think previously a lot of kids were just given the tetanus component, or a lot of adults may just get the tetanus component for their yearly, like every 10 years tetanus shot. But I think Dr. Fulton can speak a little bit more to that, but the change with adding that pertussis component to more adult vaccines hopefully will lead that to be decreasing a little bit as well.
Yeah, so Bordetella pertussis, the bacteria, we talk about it as just pertussis, and whooping cough is the disease of childhood, and it has to do with their airways being smaller. So as they cough, 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 and breathe in really hard, it creates this characteristic whoop. For adults, we more talk about it as the 100 days cough. This infection just causes a really profound inflammation in the lining of the airways, and it just takes a long time to heal. So people are pretty sick with this for a week or two with a bad cough and feeling yucky, but then they go into a several month-long process of just a cough that just will not stop. And this can result in multiple doctor's visits, often getting more antibiotics, and just kind of a really irritating illness. It does eventually get better. It does respond to antibiotics if it's recognized early. It can be life-threatening in the very elderly, although I would say in general we don't see a lot of this disease causing severe disease in the adult population. For adults, basically it's just recommended that at some point in adulthood you get a single booster shot, which frequently we just give with the tetanus shot because they're co-formulated together. There is some discussion in the big picture that because immunity to the vaccine can wane over time, that when people get their tetanus shot, maybe just every time we should add pertussis to it. That's not a formal regulation or recommendation yet, but it may get there. The idea is that they used to use many years ago pertussis bacteria that had been completely killed, but it was the whole bacteria, but it just caused too many side effects when they gave the vaccine, but even though the immunity lasted a long time. So now they're just really giving the shell of the bacteria. It's not the full bacteria, it's just some protein. So it doesn't have side effects, but it doesn't last as long either. So I think everybody should get at least one pertussis, and with special attention around pregnant women and people that are around pregnant women and young babies, just to help protect them from this infection. So I think that's the extent of what we have for presentation. Kelly, if you could help kind of share questions for us that you think seem to be coming to the surface, and we're happy to
Sure.
answer if there are any questions there are.
Yeah. Well, first, thank you both for your expertise. There were a few questions that came in. The first one that I'll put up for you all, someone in their 40s, they're asking, what are the recommended immunizations for someone who's in their 40s? Is there a list or common things, or maybe even questions that they should kind of be equipped with when they go see their provider?
Yeah, I think that's a great question. There's sort of the things that are going to be recommended for everyone, and then there's the things that are going to be recommended based on a person's particular risk factors. So from my standpoint, as a 44-year-old myself, getting a flu shot every year is just a thing to just count on. Getting a tetanus shot every 10 years is a thing to just count on. Getting a COVID shot uh, depends a little bit on your medical conditions and also who you're around and kind of what your specific needs are. Um, Beyond that, when we talked about the RSV vaccine, a 40-year-old doesn't need that one. They've already been vaccinated for measles, mumps, and rubella. A 40-year-old probably had chickenpox themselves, so they didn't get the chickenpox vaccine. Um, Depending on risk factors, they may benefit from getting the HPV vaccine series if they did not get that before. That's only been available now for 10 to 15 years, so they may not have gotten that in childhood. So there are a number of other vaccines out there, but in terms of the ones that every 40-year-old every year should be thinking about getting, definitely the flu shot, and then making sure they're up to date on tetanus. But having a regular provider, these vaccines are we keep track of all of these, and there's actually sort of guidelines based on a person's conditions, which vaccines they should be getting. So touching base with your provider about any extra vaccines would probably be the best approach.
Great, thank you. The next question, there's a question about timing. As far as vaccines, is there any kind of waiting period between? So if you don't get them together, like say you get your flu shot and then you want a COVID vaccine, should you wait a certain amount of time?
People can get influenza and COVID vaccines together. So in that sense, you don't have to wait. For me personally, what I've done is when I take COVID vaccine, it just gives me a little bit of fatigue the next day. So I try to get that done on a Friday. So I'm not at work the next day. The influenza vaccine, I generally don't have side effects with. So there is some notion that if you're sort of acutely ill and you have fevers and that sort of thing, you should probably recover from whatever illness you have before you ask your immune system to do more. But otherwise, if you want to space them out, even a week to two is, in my view, more than enough. As an infection doctor, I think one thing I want to share is, we are surrounded by all sorts of things that our immune system is constantly responding to. Both bacteria that live in our body normally, viruses that once we have them, they always live in our body normally, viruses that are out in the community, fungus that we breathe in the air. Our immune systems are so profoundly good at what they do that for me, adding an influenza and a COVID, vaccine together, your immune system is great. It's going to be able to handle stuff. So I think they can be given together, but if people have specific reasons to avoid it, a week or two is going to be more than enough for the immune system to handle that.
Great. Anything to add, Dr. Kolker? Is there anything there on the pediatric side? No? Okay.
No, I agree with all of that. Yeah.
Okay. There was a question also about when is the right time to get your COVID and flu vaccine? Is it now, or should we be waiting until later in the year?
Great question. The bottom line is get it when it's available because it's better to get it than not get it at all. I don't think that there's been any specific studies around timing that suggest getting it later in the year versus earlier in the year is definitely beneficial or harmful. I think actually some studies show it probably doesn't matter if you get it now versus later. I have heard it said that people don't want to get it too early because they don't want their immunity to wane kind of later in the year. But I'm not aware of strong data to suggest that matters. I am aware that if you don't get the vaccine, it won't work. So delaying and then kind of forgetting and missing the opportunity and then getting the infection and then getting sick, well, you missed the opportunity. So if you have the opportunity to get it, if you're at your doctor's office or you're at a pharmacy and it's available, I'd say just get it done. I don't think I have strong recommendations about timing.
Great. Um,
I'd echo that too. Sorry,
Great.
just when if we've been offering it the flu for the last month, and I just feel like it's easier when you're here to do it, and it can get put on the back burner and forget to come back. So
All right. In relation to having COVID infection, is there a wait time that someone should wait? I know you had mentioned they should be fully recovered. Is that really just the recommendation then that they're fully recovered, or is there a length of time like I think previously that was like 3 months that they recommended you kind of take advantage of that natural immunity before you get a vaccine for COVID?
I think in the general population, there's been this sort of understanding, especially during pandemic times, that if you had COVID infection, you'd wait about 3 months before you'd consider getting a vaccine. In my view, if you had a COVID infection and you were sick, you had a fever, you had a cough, you got better, you have good immunity for that. You've been essentially immunized for this season's COVID. So, somebody that had COVID 2 weeks ago, that's the current variant in our community. That's what's circulating. I really don't feel super strongly that person needs a COVID vaccine this year. They've already had their COVID infection. But for people that are immunocompromised and people that have significant health conditions, the challenge we have with vaccine versus what we call natural immunity from infection is that it's a lot harder for us to know with certainty if natural immunity has the same strength and ability to prevent severe infection compared to the vaccines, which have been studied at length and have been proven at their current dose to protect people. So I think that's where that kind of discussion happens of, who should still get a vaccine after infection. It's probably those people that are at really high risk for severe disease. But if you're somebody who's healthy that doesn't have high risk factors and you've already had an infection this year, I don't think you're going to get a lot of marginal benefit from a subsequent vaccine.
Great. We'll wrap up with one last question. How long will the flu vaccine last in someone's body? Will it decrease its efficiency over time?
Well, so the answer is we do want to do yearly influenza vaccine because immunity does wane and because it gives us the opportunity to optimize based on those surface proteins that may be occurring. So how long does it last? I think people develop protective immunity for months and months after infection. The reason we give it this time of year is we want to optimize that immune response over the next 4 to 5 months as we move through influenza season. If there was a influenza outbreak in July, how much could we rely on a vaccine in November? I don't know that anybody knows that because that doesn't occur here, but I don't know that immunity lasts all the way into next year. But I do think that getting it now versus October or November, even getting it now or a couple of weeks ago, that lasts all through the winter. And that's based on what we call antibody studies, where you can measure antibody levels in the blood, and after a vaccine, they sort of peak, and then depending on the particular disease, they may stay high for like measles forever, or for more of these respiratory viruses, they may go back down again. And for influenza in particular, that's probably like a 6 to 9 month process.
Great. Well, thank you again, everyone, for joining us, and for you, both Dr. Fulton, Dr. Kolker, for your expertise. We just want to remind everyone to please complete our survey. You'll see a link to that when the webinar ends. And then if you'd like to rewatch the webinar, you will be emailed a link to that recording as well. It should be sent to you no later than Friday, October 3rd. Thanks again for joining us, and have a great day.